our CIPCA 2 course. Today we are going to continue speaking and making discussions about our instruments which we use in CIPCA. We have been speaking about CIPCA, and now, yesterday actually, we were speaking even about the core instrument to help children express their emotions, their thoughts, and to identify positive alternatives. That is the positive expression guidelines. Do you remember yesterday's discussions?
Yes.
Have you been thinking about that? Have you any comments or questions or something that you might say about that? Sure.
We asked a lot of questions yesterday.
You asked a lot of questions. You are clever students. That's good. Because if you ask us how you can help children express thoughts and emotions during the crisis situation, then we know that we have to follow special steps and we have to ask some questions which are called Socratic questions, starting with open questions in order to let the child spontaneously speak about feelings and emotions and memories. And now we can go to the next instrument, which is the screening instrument. You know, you are going to train group leaders, and every 2 group leaders are going to provide the group intervention for maximally 30 children in a group. Either children from 6 or 5 to 11 years age, or adolescents from 12 to 18 years. And one of the group leaders will be the leader of the conversation using the expression guidelines, while the other one is a passive observer, having this instrument in his hand, crisis screening instrument, and observing the children during the intervention. Any of these symptoms, if they appear on a child, then the group leader is going to record the name and the telephone number of the caregiver of that child, identifying the symptom in order to refer the child to nearest clinic for child psychiatric assessment. If we start looking at this instrument, we see that most of the psychological distress symptoms appears like that. You see, if you can notice that the first symptom, not responding to the question or refusing to participate, what does this indicate usually? If a child is not responding to your question, if the child is refusing counseling, seems to not bother about that, seems to not to be concerned, try to go out, try to leave you, try to interrupt the conversations. What does this mean? Why the child is doing that? experiencing. Okay?
Sometimes maybe she already had a problem with speaking, and she can speak, she can experience her feeling, or maybe this patient remembers something about the event happened for him or her, and at that time she can speak about this because she avoiding this, to not remember everything about this, even this situation. So for that, maybe refuse to income or participating to helping for this or cooperation with you for this, or just be silent and do not put your eyes, have no eye contact, maybe working. Maybe it is often if she didn't remember this event, and after that she feels too much stress inside to this way.
Very nice. Thank you very much. Actually, you reminded me about something which I didn't think about that. That is, if the child has any difficulties before, so the condition may be not related to the current crisis. Probably the child has some difficulties in speech, in communication, social interaction, and that will also give you an indication to interact in a different way. So that's nice, thank you. In addition to, of course, the psychological defense mechanisms that make the child avoiding to speak about the difficulties, which is one of the symptoms of post-traumatic stress syndrome, if it has developed, or acute stress disorder also, actually. So that's right. Good. Anything to comment or?
It's the same. I was thinking about avoidance or like withdrawal or sometimes dissociation. Like it's nothing to do with him.
Good.
So if it's like sometimes maybe it's one of the signs of PTSD.
That's right. That's right. Thank you.
Can I ask something about dissociation?
Yes?
How much type of dissociation you have? Sometimes maybe you have a emotion and you become far from them. Or another type that you now for the child, not for the over them.
Your voice was very good first. Now you are
Yes.
going down again.
I-
What's the matter? What's the matter with you? Come back to the high voice, please.
When we have an event,
Yeah.
and when this child speak about the event and remember everything, and at that time dissociation happens for this child. Are the dissociation of the child something at another age? The same? If I have dissociation and the child has dissociation, is it the same?
Okay. I understand. Of course, everything, while it is emotional or cognitive or behavior, and these constitutes our psychology, is related, everything is related to the age and developmental level. So differences are both in the conception of the, how do you receive perception of the event of something. We perceive the informations according to our understanding of the event. So even there, receiving any stimuli from the surroundings will be accepted or integrated or soluted in the brain according to the developmental level of the brain and the centers. That's why it is already there will be differences related to the age and the developmental. And the other thing, how do you express your thoughts and your emotions and how do you behave is also related to your developmental level. So that's right.
How much time do you have?
How much?
Time.
How much time? There are many as human beings. But the difference is, you can have clusters of clinical pictures. So, for example, most common dissociation type among children is derealization. Derealization. And the other one is depersonalization. You understand that? Derealization, can you give me an example of that? Derealization.
Can accept the reality thing?
Yeah?
Can accept the reality thing. This situation happened for them. Can accept it. Can become a reality in their mind.
At the contrary, right?
Can you say?
At the contrary, like
In the contrary.
as if he is not understanding or it's not real. So it's like associated, like as if he was not there or he's not.
That's right. It's more like that. Derealization means that changing in your real situation. You will feel that the things are not as real. This room is not a room. It is a car. It is something which is not real. The walls are moving and they are constituting of something which is soon or they will be causing harm or causing something else. The surroundings is not open, is not clear. You probably are finding yourself in a vala, you call it, something which is not clear, diffuse, in the clouds. These are examples of derealization. The reality around you is changed. It's not as real as it should be. That's the
Hyperorientation. Hyperorientation. When the patient comes to you and you ask about this day, which is very, it's not dates,
okay. Yeah, that's why orientation actually is also can be affected by trauma. You can feel that you are not, you don't know where you are, or which day it is, or what's your name, or what's the name of others. So this orientation is another term. Usually it's connected more to neurological perception. But it can be one of the clinical pictures of trauma. And it can indicate actually dissociation also. It can include that. But usually if I find these signs among a patient, I will think more about a biological disturbance more than the psychological. If it is only disorientation.
But about this derealization, like someone falling down, at that time we can explain this derealization or depersonalization.
Okay.
At that time, or how can I just wondering because I do not know explain this type of.
Of course. It is during the appearance of the clinical picture. The clinical picture of the child will show you if it is derealization, disorientation, fainting. One of the types of conversation is fainting, or it is depersonalization. And depersonalization, can you give me an example?
Well, once I've seen a case, I didn't know that it's part of dissociation, but later when I read, she was on, later on we discovered that she was on sexual abuse since childhood. So she was thinking that when she presented to us, it was like as if there's another person inside her. And like she came with disturbed like behaviors. The parents came saying that once she said, I want to go to that school, the next day she went, no, I told you I don't want to go to that school, I want to go to another school. They transferred her, after 2 days she said, why I can't, something like that. So when she came, she she said, yes, there is some, these cultural ideas about demons, jinn, something like that. And it's inside me. And these things, it's not me who I'm saying. It's that thing inside me. He's controlling me. Sometimes it's me. Sometimes it's the other person. So she even, when she looked to the mirror, for example, she used to say, "This is not me." Now I'm seeing. So that as if there are two personalities or two persons.
Exactly. This is a type of dissociation also. And it is actually most common among sexual abuse girls and women. And it appears also related to the age and duration of the abuse, of course. So it is related to how long time it has been the abuse and the age of the victim, of the person, and how long has been passed after that. Because, if it is in the beginning, this dissociation is a kind of derealization. That means derealization that the things which are happening, the things which are happening during the abuse time are not the same. So the perception of the victim will be that I am not here, this is not happening here, this person is not doing that, and in order to survive the abuse. But it may be also depersonalization, and this is most common among abusers, I say. That is to say, this is not happening to me. I am not a sexual victim. This sexual activity is happening to somebody else. So this dissociation is during the act of sexual abuse. That's why the victim usually don't remember that after that. If you ask the victim or survivor of the sexual abuse, it is common to hear that they have not been abused. It is not the abuse, it is the speech of the people, it is the description of the people. Until during the therapy, they can remember some points, some events of the act of sexual abuse, in order to connect them then in an event, in order to get the old memory back and to describe the event. And this is type of dissociation. The problem is development of multiple personality disorder. Because if those sexual abuse during childhood don't receive adequate management, then they are going to grow up with these kinds of dissociations. These are, in the beginning, in the start, psychological defense mechanisms. And they are normal. It's not a pathology. It's normal defense mechanism in order to survive an abnormal situation. A normal reaction to an abnormal situation. The problem is if they become standing a long time after that, then they will develop from a kind of defense mechanism to a survival strategy. That means that the feeling of dissociation will remain as part of this person. So this person gradually will show, as you described, Mr. Baira, will show two kinds of personalities. Sometimes don't remember her name, don't remember her place, and gradually developing two names, two personalities doing different things, actually. So multiple personality disorder during adulthood many times is referred to childhood abuse, mostly sexual abuse. That's right. Yes.
I don't know about children, but as you said, it's mostly the abuse ones. But shall we keep it, like, okay, let it remain as a defense mechanism, or we need to let them realize that this is not right, this is a defense mechanism, or it's okay to keep it like that, like a defense mechanism?
Good. That's a very good question. You know, for every trauma, you have to stop the trauma. The first step you do is to remove the child from the traumatic situation. Remove change the situation in any way. When you do that, then you will see how the child is doing. If the child still shows dissociation symptoms, then it is a risk for development of pathology. And we have to consider the time after that. Usually one say, within 1 month after surviving any trauma, sharing the post-traumatic symptoms is okay. It's still a kind of survival reaction. It is normal reaction. When it becomes pathology, when the things are becoming constant, permanent, and continuous, we have to think that it may be individual many times, but we have to have also determine the time. That's why in the clinical settings and even in research, the criteria of pathological development are considered within 1 month, after 1 month. Some clinicians still say, no, the first 6 months I can accept appearance of some kinds of post-traumatic stress. But if we look at the DSM criteria, for example, if we look at the classification of diagnosis, both ICD-10 and DSM, you will see that 1 month is considered a good limit of normality. After that, you consider it as a pathology. Right. That was about dissociation. The second point, which also in our instrument, is related to that seems mostly absent, daydreaming, sleeping during the intervention. Do you think of something else more, maybe indicating this symptom, more than dissociation and psychological defense mechanisms? Okay. Next one is hypersensitive to stimuli, startle overreaction. What do you have for comments or questions or description of that? Yeah? Reacting to the stimuli, overreacting to the stimuli actually. Startle.
Just example for this hypersensitive example. It's not clear for
This hypersensitivity is not that hypersensitivity of allergy. You know, in medicine, you can be hypersensitive to the bites of insects, to some food. You can react to that in inadequate way. You can be sick of that. This is a type of hypersensitivity which is related to the immunity to the biological reactions of the body. Here we mean another type of hypersensitivity. And that is how you react to the stimuli to your sensory organs. For example, you cannot have exposure to light, strong light. When you You are in the dark rooms, you can accept it, you are calm. As soon as you be exposed to the light, to the lamp, usual, normal, then the patient may react very strongly and close the eyes and scream escape from the place. This is one example of hypersensitivity. It may be hypersensitive to every stimuli, for the smells, for the tastes, for hearing voices. So this hypersensitivity to stimuli, any stimuli, taking just tactile, taking the hand of a victim of a sexual abuse, for example, then they will react and scream. These are hypersensitive. And the startle overreaction, you don't need to have direct stimulation. Hearing just about a door closing, a window is closing, then you can jump. Somebody coming back from you saying, then you can jump. And it is a normal reaction actually. But if you do several times, if you don't have that overreaction, then you will realize it's normal. But the PTSD patients, for example, still react. Every time you say they will react, they will jump up. This is the type of startle reaction as a reaction to post-traumatic symptoms. Anything more about this? No. We go to number 4, crying or depressed.